Hi, my name is Gianam. I'm a myotherapist. Today I would like to provide the definition for deconditioned myofascia. Most physical therapy research is based on sports injury and rehabilitation. However, common musculoskeletal pain complaints are idiopathic in nature. So the question is, does physical therapy still apply to common musculoskeletal pain? And my opinion is yes. I think that the biomechanical concept of myofascial dysfunction applies to common musculoskeletal pain conditions such as tendinopathy, Yanda's upper and lower cross syndromes, lower back pain, knee, thigh and ankle pain, shoulder pain, and so on. The biomechanical concept involves perceiving a moving body as an object in space with tension and compression forces acting on it. Somewhere on the biomechanical myofascial network structure called the kinetic chain, there is a weakest link. In our assessment of the kinetic chain, we will call it deconditioned myofascia. Deconditioned myofascia is the term we give to structure that is affected by myofascial restrictions. The myofascial structure does not lengthen when the joint is passively stretched. The agonists of the deconditioned myofascia contract instead to move the joint. Moreover, during physical exertion, the deconditioned myofascia moves with the synergistic myofascia. In other words, the deconditioned myofascia is dysfunctional biomechanical tissue. The greater the physical exertion or load, the greater it would reinforce the structural imbalance. At worst case, it leads to irreparable cellular degeneration and muscle atrophy. In most common situations though, you experience myofascial pain syndrome due to compensatory mechanisms of your body as you react to neurophysiological stresses. According to Vladimir Yanda, phasic myofasciae become weak and inhibited, whereas postural myofasciae become tight. Because the tissue does not lengthen using a passive stretch, a possible outcome from deconditioned myofascia is tendon injury. There is a risk of developing a condition called tendinopathy. In our physical assessment of how forces cross the pelvic junction of our body, we need to consider the co-contraction of groups of myofasciae that contribute to the force closure mechanism proposed by Andrew Vleeming, which include posterior oblique sling system, deep longitudinal sling system, anterior oblique sling system, and lateral sling system.